This recording will go over hemorrhoids and malabsorption syndrome. Hemorrhoids are unnaturally swollen or distended veins in the anal-rectal region. Hemorrhoids can be internal or external. Internal hemorrhoids, which cannot be seen on inspection of the perineal area, lie above the anal sphincter. External hemorrhoids lie below the anal sphincter and can be seen on inspection of the anal region. Prolapsed hemorrhoids can become thrombosed or inflamed, or they can bleed. Hemorrhoids are common and not significant unless they cause pain or bleeding. Because of the increase in abdominal pressure, the condition worsens during pregnancy or with constipation with straining, obesity, heart failure, prolonged sitting or standing, and strenuous exercise and weightlifting. Decreased fluid intake can also cause hemorrhoids because of the development of hard stool and subsequent constipation. Straining while evacuating stool causes hemorrhoids to enlarge. Prevention of constipation is the most essential measure to address hemorrhoids. It can be prevented by increasing fiber in the diet, such as eating more whole grains and raw vegetables and fruits. Encourage patients to drink plenty of water unless otherwise contraindicated. Remind the patient to avoid straining at stool. Remind him or her to exercise regularly with a gradual buildup in intensity. Maintaining a healthy weight also helps prevent hemorrhoids. The most common symptoms of hemorrhoids are bleeding, swelling, and prolapse or bulging. Blood is characteristically bright red and is present on toilet tissue or streaked in the stool. Pain is a common symptom and is often associated with thrombosis, especially if thrombus occurs suddenly. Other symptoms include itching and mucus discharge. Diagnosis is usually made by inspection and digital examination. Interventions are typically conservative and are aimed at reducing symptoms with minimal discomfort, costs, and time loss from usual activities. Local treatment and nutrition therapy are used when symptoms begin. Cold packs, applied to the anorectal region for a few minutes at a time, beginning with the onset of pain, and tepid sitz bath 3 to 4 times per day are often enough to relieve discomfort, even if the hemorrhoids are thrombosed. Topical anesthetics, such as lidocaine, are useful for severe pain. If itching or inflammation is present, the primary healthcare provider prescribes a steroid preparation, such as hydrocortisone. Cleansing the anal area with moistened cleansing tissues rather than standard toilet tissue helps avoid irritation. The anal area should be cleansed gently by dabbing rather than wiping. Diets high in fiber and fluids are recommended to promote regular bowel movements without straining. Stool softeners, such as docusate sodium or polyethylene glycol, can be used temporarily. Irritating laxatives are avoided, as are foods and beverages that can make hemorrhoids worse. Spicy foods, nuts, coffee, and alcohol can be irritating. Remind patients to avoid sitting for long periods. The primary health care provider may prescribe mild oral analgesics for pain if hemorrhoids are thrombosed. Conservative treatment should alleviate symptoms in 3 to 5 days. If symptoms continue or recur frequently, the patient may require surgical intervention. The surgeon can perform several procedures in an ambulatory care setting to remove symptomatic hemorrhoids, such as a hemorrhoidectomy. Complications of these procedures include pain, thrombosis of other hemorrhoids, infection, bleeding, and abscess formation. Teach patients with hemorrhoids about the need to eat high fiber, high fluid diets to promote regular bowel movements before and after surgery. Advise them to avoid stimulant laxatives, which can be habit forming. For patients who undergo any type of surgical intervention, monitor for bleeding and pain after surgery and teach them to report these problems to the healthcare provider. Using moist heat, such as sitz baths or warm compresses, 3 to 4 times per day can help promote comfort. Tell the patient who has had surgical intervention for hemorrhoids that the first post-op bowel movement may be very painful. Be sure that someone is with or near the patient when this happens. Some patients become lightheaded and diaphoretic and may have a syncope related to the vasovagal response. The healthcare provider usually prescribes stool softeners, such as docusate, to begin before surgery and continue after surgery. Analgesics and anti-inflammatory drugs are prescribed. A mild laxative should be administered if the patient has not had a bowel movement by the 3rd post-op day. Malabsorption is a syndrome associated with a variety of disorders and intestinal surgical procedures. The nutrient involved in malabsorption depends on the type and location of the abnormality in the intestinal tract. Deficiencies of bile salts can lead to malabsorption of fats and fat-soluble vitamins. Remember, your fat-soluble vitamins are A, D, E, and K. Bile salt deficiencies can result from decreased synthesis of bile in the liver, bile obstruction, or alteration of bile salt absorption in the small intestine. Lactase deficiency, and you know it's an enzyme because of that ASE ending, lactase. Lactase deficiency results in the body not being able to break down lactose. Pancreatic enzymes are necessary for the absorption of vitamin B12. With destruction or obstruction of the pancreas or insufficient pancreatic stimulation, this nutrient is not well absorbed. Chronic pancreatitis, pancreatic carcinoma, resection of the pancreas, and cystic fibrosis can cause these malabsorption problems. Loops of the bowel can accumulate intestinal contents, resulting in bacterial overgrowth when peristalsis is decreased. Bacteria at these sites break down bile salts, and fewer salts are available for fat absorption. These bacteria can also ingest vitamin B12, which contributes to a vitamin B12 deficiency. This process can occur after a gastrectomy. Obstruction to lymphatic flow in the intestine can lead to loss of plasma proteins, along with loss of minerals, vitamin B12, folic acid, and lipids. Interference with blood flow to the intestinal mucosa results in malabsorption. With intestinal surgery, there is loss of the surface area needed to facilitate absorption. Resection of the ileum results in vitamin B12, bile salt, and other nutrient deficiencies. Gastric surgery is one of the most common causes of malabsorption and maldigestion. Chronic diarrhea is a classic symptom of malabsorption. It occurs as a result of unabsorbed nutrients, which add to the bulk of the stool and unabsorbed fat. Steatorrhea, which is greater than normal amounts of fat in the feces, is a common sign. With steatorrhea, the stool appears oily and has a foul odor and frequently will float because of the fat content in it. It is a result of bile salt deconjugation, non-absorbed fats, or bacteria in the intestine. Not all patients with malabsorption have diarrhea. Instead, some have an increased stool mass. Other symptoms include unintentional weight loss, bloating and flatus, decreased libido, easy bruising, anemia, bone pain, and edema. Lab results can help determine what type of anemia the patient is suffering from. They may have iron deficiency anemia or pernicious anemia. Serum iron levels are low in protein malabsorption because of insufficient gastric acid for use of iron. Serum cholesterol levels may be low from decreased absorption and digestion of fats. Low serum calcium levels may indicate malabsorption of vitamin D and amino acids. Low levels of serum vitamin A and carotene as precursor indicate a bile salt deficiency and malabsorption of fat. Serum albumin and total protein levels are low if protein is lost. A quantitative fecal fat analysis is often elevated in either malabsorption or maldigestive disorders. A lactose tolerance test or hydrogen breath test can be used to test for problems digesting lactose. The Schilling test measures urinary excretion of vitamin B12 for diagnosis of pernicious anemia and a variety of other malabsorption syndromes. The bile acid breath test assesses for absorption of bile salt. Ultrasound is used to diagnose pancreatic tumors or tumors in the small intestine that are causing malabsorption. X-ray and CT may also be used. Interventions for most malabsorption syndromes focus on avoiding the substance that aggravate malabsorption and supplementation of nutrients. Surgical management of the primary disease may be indicated. Drug therapy may also improve or resolve malabsorption. Nutrition management includes a low-fat diet for patients who have gallbladder disease, severe steatorrhea, or cystic fibrosis. After a total gastrectomy, a high-protein, high-calorie diet and small, frequent meals are recommended. Lactose-free or lactose-restricted diets are available for patients with lactase deficiency, and gluten-free diets are available for those with celiac disease. The healthcare provider prescribes nutrition supplements according to the specific deficiencies. Common supplements include water-soluble vitamins such as folic acid and vitamin B complex. Fat-soluble vitamins such as A, D, E, and K, minerals such as calcium, iron, and magnesium, and pancreatic enzymes such as pancrelipase. Antibiotics are used to treat disorders involving bacterial overgrowth. Drug therapy is used to control the signs and symptoms of malabsorption. Antidiarrheals can be used to treat diarrhea and steatorrhea. Anticholinergics may be given before meals to inhibit gastric motility. IV fluids may be necessary to replenish fluid loss associated with diarrhea. Provide special measures to protect the skin when chronic diarrhea occurs. Please review the chart for special skin care for patients with chronic diarrhea on your own. Patients with steatorrhea are monitored for fluid and electrolyte balance and are encouraged to drink electrolyte-rich liquids liberally. Teach them the rationale for dietary, drug, and surgical management of nutritional deficiencies and evaluate interventions on the basis of changes in or resolutions of signs and symptoms. Please pause the video to read the questions and figure out your answers, and then resume the video to see if you're right. For the first case study question, the correct answer is positive family history with first-degree relatives, dietary habits, red meat and fried foods, and a history of ulcerative colitis and prostate cancer. For the second case study question, the correct answer is D, as in dog. The most common signs of colorectal cancer are rectal bleeding and anemia. For case study question number 3, the correct answer is D, as in dog. Tumors of the rectal sigmoid colon are associated with hematochezia, the passing of red blood via the rectum. This tumor location is also associated with straining to pass stools and narrowing of stools. Additionally, the patient may report dull pain. For question 1 here, reddish, pink, moist, and protrudes about 2 centimeters from the abdominal wall is how the nurse would document this finding. Initially, the stoma may be slightly edematous and there may be a small amount of bleeding. For question number 2, the correct answer is about 2 to 4 days post-op. The correct answer for this question is D. Immediate post-op stool may be liquid, but it becomes more solid depending on the location of the colostomy. Stool from the ascending colon colostomy will be more liquid. Stool from the transverse colon colostomy will be more pasty. And stool from the descending or sigmoid colostomy is more solid and similar to the usual stool expelled from the rectum. The correct answers for this question are A, B, C, and D. The correct answer for this question is B, as in boy. The correct answer is D, as in dog. The correct answer is D, as in dog.